Flipped next. You can go ahead and flip it to the next slide if you'd like. I'm Suann Gaydos, and I'm a WVU School of Dentistry professor, a dental hygienist by trade. And on top of teaching and helping students learn how to clean teeth, I also direct the Certified Tobacco Treatment Training Program, which is housed in the School of Dentistry. It's one of 28 accredited programs to help healthcare providers increase their tobacco treatment knowledge, skill, and competence. And if you're successful with the online self-paced training program, you can receive credentials of being a certified tobacco treatment specialist. There are 24 contact hours associated with the online program and a $750 registration fee if you're interested. The QR code should take you to more information about it too. Next slide, please. So today's presentation, I'm going to briefly review health risks of tobacco products with specificity to lung disease, and then review tobacco-based tobacco treatment or tobacco cessation strategies to help increase abstinence rates. Next. So just remember that tobacco use disorder is a chronic disease and should be treated like any other chronic disease. Just to review some of the health risks on the left-hand side, smoking causes cancers throughout the body. It really stiffens the vessels throughout the body, so it ends up with cerebrovascular disease. It can cause blindness, cataracts. Nicotine increases the pro-inflammatory mediators and delays our immune response, so it can lead to periodontitis, which is why it's housed in the School of Dentistry. That's gum disease, cardiovascular and respiratory diseases. It can cause bone fractures and decrease fertility. And even being exposed to secondhand smoke can impair lung function and cause decreased respiratory, can cause lower respiratory illness or result in lung cancer. And then vaping is considered less harmful than smoking because you're not exposed to the tar that's in smoked products, but it has its own set of risks. It dries the mouth, lowers the immune response, and the flavoring agents within the aerosol can scar the lung air sacs, increase the risk of cardiovascular disease because of the severe cardiovascular or vasoconstriction, so it can increase the risk of cardiovascular disease, stress, hypertension, and there are tons of carcinogens in it and toxic metals, which cause cancer and damage the lungs. Next. We'll talk a little more about vaping, because if it's used in adolescence before the prefrontal cortex is fully formed, it can increase anxiety, compulsive behaviors, cause mood disturbances, and impair the adolescent's ability to pay attention, retain facts, and apply learned information. Because all of this nicotine alters the levels of dopamine and serotonin, those who vape are 2.4 times more likely to be diagnosed with depression. And adolescents become addicted more easily, leading to lifelong addiction to nicotine, or it can lead to addiction to other substances of abuse when used early. Next. I want to speak briefly about these very popular nicotine pouches that are out right now. And I want to make it very clear that they're not the same as FDA-approved nicotine replacement therapies. The content within these sachets and the amount of nicotine have not been fully researched, and they don't really know the exact amount of nicotine in each sachet. They're filled with synthetic nicotine salts that are delivered to the receptors in the brain much quicker than NRT. It makes them very, very addictive. So the end result of use from nicotine pouches is that it can damage the mucosal lining in the mouth where they're held. It can lead to cardio and cerebrovascular disease and can cause cognitive delay, depression, and anxiety. Next. Go ahead and click a couple times until yellow appears, please. So these are all the chemicals that are found in vaping aerosols. The ones in yellow are known to be harmful. Simply put, e-cigarettes produce vapor that contain propylene glycol, glycerin, flavoring agents, and nicotine and other harmful chemicals known to cause inflammation throughout the body and cancer. Next. This next study is specific to vaping and lung cancer, and it shows the common additives and contaminants in vaping fluids that lead to cancer. So ethylene maltol is a common artificial sweetener. It's been shown to damage lung airway epithelial cells, cause inflammation and cytotoxicity in the lung tissues. Menthol is the agent that helps smooth and cool the inhalant. So there are also menthol cigarettes. It is linked with increased inflammation and really increases the nicotine dependence because it makes inhalation much easier. Diacetyl and vitamin E both damage the lungs. Vitamin E is linked with EVALI, or e-cigarette associated vaping-induced lung injury. And vitamin E also converts to carcinogenic compound benzene when it's heated. Cannabis can also lead to lung cancer and heavy metals such as nickel and chromium, which are known carcinogens, are also in vaped aerosols. Next. So this is just an overview of everything that I just said associated with the lung. So the flavoring agents damage the lung epithelial cells, cause inflammation and cytotoxicity. Vitamin E converts to benzene and can lead to vaping-induced lung injury. And all of the chemicals that are in addition to these other agents can cause cancer and respiratory diseases that are listed. Next. So an overview of the overall health effects is that vaping can lead to cardiovascular, cerebrovascular disease. It can, if used during pregnancy, can cause preeclampsia and placental vascular decreased function. There's a really interesting study that was performed here at WVU that is the second listed reference that shows when mice pups are exposed to vaping during gestation, they're born with very stiff vessels, which increases their risk for heart disease at a very early age and decreases their cognitive ability. Their study showed that these pups that were exposed during gestation could not get through the maze as quickly as the mice pups that weren't exposed. And then lung, thyroid, and bladder cancer are linked in other studies associated with vaping. And I wouldn't be a dental hygienist if I didn't talk about how vaping dries the mouth, leading to an increased risk of cavities. And it really affects alveolar bone loss and how the body responds to pathogens that cause gum disease, and is strongly linked with oral cancer. Next. So why is it so hard to quit? When nicotine is inhaled, it only takes it about 10 to 20 seconds to cross the blood-brain barrier and reach the nicotinic acetylcholine receptors in the brain. When nicotine mimics acetylcholine, causing a release, if you'll go ahead and click to the next slide, a release of several neurotransmitters, which are listed on the right-hand side. These neurotransmitters lead to a heightened alertness, improved mood, and increase in cognitive performance. Nicotine is a potent psychoactive agent reinforcing the use of nicotine over and over and over. And when you don't have nicotine, go ahead and click, it leads to withdrawal symptoms, which can appear within 4 hours of the last use of nicotine. These can be very uncomfortable, causing the person to be very irritable, to crave their tobacco or nicotine product. They feel sad or have anxiety. They can't think as well. They can report headaches, not sleeping well, and becoming very hungry. The average amount of weight gained during tobacco cessation can be up to 10 to 20 pounds. Flip, go ahead and change.
You have a question that was put in the chat. Somebody had asked if you had data on risk of marijuana smoking.
That's not really my focus. I don't. But that study does have more information about, that was referenced on the slide, has more information about cannabis in the lung. So the desire to quit is really quite high. About 70% of those who smoke say they would like to quit, but sadly, only about 44% try because of the physical and mental and social aspects that make quitting so difficult. And we know if somebody tries to quit unaided, meaning cold turkey, or they don't use behavioral counseling or the available pharmacotherapy, only about 3 to 6% are able to achieve abstinence. Click. Go ahead and change. We know when we use behavioral interventions and pharmacotherapy together that it doubles abstinence rates. So rather than only having a 3 to 6% chance, we can double that by using our behavioral counseling skills and approved pharmacotherapy. Before I go any further with this slide, do know that the approved pharmacotherapy for tobacco cessation, those that are approved by the FDA, are approved for smoking for cigarettes, but several smaller studies do show that they are very effective with smokeless tobacco and with vaping. So feel very comfortable using these for vaping and smokeless tobacco also. The specific pharmacotherapy that we're going to talk about today, first, varenicline is my personal favorite. It reduces the favorable effects experienced while smoking and also reduces withdrawal symptoms. Nicotine replacement therapies were developed to reduce withdrawal symptoms, and bupropion SR or Zyban, which is an antidepressant, inhibits dopamine reuptake. Next slide. So once a patient is identified as a tobacco user, tools are available to assess their readiness for change. My very last slide lists 3 tobacco assessment tools, but some are the Fagerstom for smoking and for smokeless, and then there are 3 or 4 separate assessments to determine how ready somebody is to, or how dependent they are on nicotine. Healthcare providers can help patients move from the pre-contemplative stage to contemplative into preparation, where plans are made to initiate pharmacotherapy. Combined use of behavioral and drug therapy can dramatically improve the chance for somebody successfully quitting. So let's go, you can go ahead and switch to the next slide. Let's go ahead and talk about specific goals when somebody is not quite ready. They're in the pre-contemplative stage, meaning they have no intent to quit within the next 6 months. So try to raise their awareness, but without directive pressure. So first, try to avoid that writing reflex by telling them why you think they need to quit, and instead try to build rapport. Show your empathy. Remember that it is a true addiction and most really do want to quit, and it leads to many chronic diseases throughout the body. And most people know that. It's just very hard to get away from it. You can also explore their ambivalence or their confliction about using and not wanting to use by determining their personal pros and cons about why they're using that specific product. And when they reveal their pros and cons of smoking or vaping or using smokeless tobacco, stay quiet and let it sink in for a little bit. And then say, well, when you're ready to quit, I can offer some really effective treatments that will make it much easier for you. Next slide. The goals during contemplation can be easily guided through reasons why they personally want to quit by using ORs, which is first the use of open-ended questions that are questions that they can't answer yes or no to. An example would be, what do you enjoy most about using tobacco? So that would be their pro. Or what would your life look like if you didn't smoke? Another pro for why they are smoking. That will reveal their personal choice for using tobacco every single day. The A in OR stands for affirmations. So this is when we're going to recognize our patient's strength. So maybe in your conversation, they shared that they were able to quit for 1 day or 2 days or 3 years, and then they relapsed. Or also recognize that they have valid reasons for smoking. An example somebody may share is that it helps them manage their stress. Using reflective listening helps the patient feel very heard and that it helps show your empathy. So when you repeat back what they're saying, it helps validate their feelings. It helps them trust you more. And then summarizing is just a brief recap of the entire conversation you've had, and it highlights their ambivalence to make it clear that they have reasons to use tobacco and not use tobacco, and it helps them hear their own motivations for or against change. Again, in the contemplative stage, you can always end the conversation with, when you're ready to quit, I have some knowledge that will help make it much easier for you. You can go ahead to the next slide. And then my favorite stage of change is when they are in preparation. They are ready to set a quit date, remind them to clear their environment of their product of choice. This should not say remover triggers, it should say remove triggers. So this could be their ashtray in their room, or just simply having their vape laying around or their can of smokeless around the house. Clean their house so it no longer smells like cigarette smoke, and help them set boundaries for those that they're going to be around. Remember that there are some really great support systems now. The Quit line not only has a phone number that you can call, but they have texting and chat and online options. And there are just a ton of really helpful cessation apps available now. Make sure that individuals are aware of these and are encouraged to use them. Then in this preparation phase, you can talk briefly about the available pharmacotherapy and focus more on the ones that they seem more interested in, and then help build their personal coping plan. Next slide. Some of the mental coping skills that we can use are to encourage them to make a list of their personal reasons why they want to quit and post it somewhere where they review it often. Also, they can post reminders of their personal benefit to quitting. Make sure that they know that these withdrawal symptoms and the urge to smoke will go away within a few minutes. They can make a list of situations that trigger them to smoke, vape, or dip, and go through a plan on refusal skills. And then also just reviewing progress and rewarding themselves in some way. A lot of people say that calculating out how much money they're saving by not purchasing their tobacco products is a great motivator. Next slide. Some of the behavioral coping strategies, which are really easy to share, are just encourage the patient to leave a situation when they're getting that strong urge to smoke or vape or use smokeless. And during that time, take a 5-minute time out, close their eyes, take deep breaths, or even better, take a brisk walk to help release those neurotransmitters that they're used to getting when they use tobacco. They can distract themselves by squeezing rubber balls, using cinnamon sticks to have that hand-to-mouth action. And then another, I don't know if you can see this very well, but the picture right beside Keep Hands Busy are the necklaces that are available. They're really not very expensive, and they do that same hand to mouth and give them something to inhale within, and it's right there hanging around their neck. I've had several clients report back that those really helped them. Soothing music and trying to keep their minds filled with a hobby or a pleasurable activity also work very well. And I wouldn't be a dental hygienist if I didn't say brush your teeth more often, because it helps your mouth feel refreshed. Next slide, please. So now we're going to go through the various pharmacotherapies. Next slide. The goal of these are to control withdrawal symptoms or to reduce that rewarding effect from using tobacco. The initial pharmacotherapy dose is dependent on how severely addicted they are to the product, meaning really how much nicotine is in the product. And it can also be dependent on their ability to tolerate the withdrawal and their willingness to use pharmacotherapy. Remember again that this is a chronic condition. So really, you shouldn't even think twice about offering pharmacotherapy to people that when they're ready to quit. And there are specific timelines for the doses, but these can be increased for the length of time if needed. Next slide. So the 6 that are currently approved for smoking cessation but can be used off-label for vaping and smokeless. The first 3 are available over the counter, very easy for individuals to get. The nicotine patch is considered a long-release nicotine product. It provides a relatively constant level of nicotine throughout the day, but it does take about 6 to 8 hours to reach its peak nicotine level. So individuals need to be aware of that, because if they're not told and they place that nicotine patch on, they're going to expect it to work within 10 to 20 seconds like their cigarettes, and it doesn't. It's a long release. So combining it with the next 3 short releases can be very effective. The nicotine gum, nicotine lozenge, and nicotine nasal spray are all considered short release. They work for up to about 30 minutes. The gum and the lozenge get nicotine to the receptors in the brain and reach their peak in about 15 to 30 minutes. And the nasal spray is much faster, in 5 to 10 minutes. Bupropion and varenicline are the 2 prescribed tablets that they can take. Bupropion is an antidepressant and it inhibits dopamine reuptake, and varenicline is a partial agonist of the receptors in the brain, and it removes reinforcing effects of nicotine. Next slide. When somebody is moderately or severely dependent on nicotine, varenicline, if they only want to use one product, is the most effective. And then the next, which is also very effective, is combining the long release nicotine patch with a short release nicotine gum lozenge and spray. Next slide. Before we go into nicotine replacement therapy, you have to know the nicotine content in tobacco products. And vaping makes this very, very complicated. For cigarettes, it's fairly easy. There's about 1 milligram in each cigarette. So if they're smoking a pack of cigarettes, they need to be dosed with a nicotine replacement therapy patch that is equivalent to 20 milligrams. A large cigar takes about 1 to 2 hours to smoke, and at the end of that, they are receiving about 20 milligrams of nicotine in one large cigar. Cigarillos are about 3 milligrams, and little cigars are the same as a cigarette, about a milligram. A can of smokeless has a ton of nicotine in it. It's about 80 milligrams. And that's specific for the brands that are very popular in West Virginia because there is a slight range. But on an average, if you think 80 milligrams, you can dose your nicotine patch to that. If they're using a can a week, you're going to divide 80 by 7, and that is about 11 milligrams. So you would want to dose them with at least a 14 milligram nicotine patch to reach that. Now, vapes. Disposable vapes. So we're talking about the very popular ones that you can just use and throw away. So some popular brands are Geek Bars, Elf Bars. That's what I'm talking about here. They have a lot of nicotine in them, about 50 milligrams, but some of that is lost in the aerosol. So really about 68% of that is absorbed. So with these disposable vapes, dose your nicotine patch to about 34 milligrams. And mods are the types of vapes that you fill your own e-liquid in. They're larger, they hold more nicotine. So most of the mod devices hold about 90 milligrams. And when you do that 68 absorption rate calculation, it makes mod vapes about 61 milligrams. So that gives you an overview of the amount of nicotine that a person is exposed to so that you can dose your nicotine patch appropriately. And that's what we're going to talk about on the next slide. So in the United States, the nicotine patch, which you peel off the back layer, and it's just most of them are either skin colored, a tan color, or now see-through so that it matches any skin color. They come in 3 different doses, 7, 14, and 21 milligrams. And again, you're going to recommend the dose that reaches the amount of nicotine that they are using. So if they're smoking 2 packs a day, they're going to start with 2 21 milligram patches. And that is okay. There are lots of studies out on using multiple patches. And the only time that people got really physically ill was when they were wearing about 6 patches at one time. So 2 patches a day is going to be just fine. It's going to keep their withdrawal symptoms from happening. They're used to that amount of nicotine every single day anyway. And then you can see the other recommendations based on lower amounts of cigarettes per day. But the Chest Foundation made this even easier. It's a really nice tobacco treatment toolkit that I like. It's CHEST toolkit. It says if they're smoking less than 10 cigarettes a day, start with the 14 milligram patch. And if they're smoking more than 10 cigarettes a day, then start them on the 21 milligram patch. It makes it really easy. And then you just need to know they'll need more than a 21 milligram if they're smoking more than a pack a day. Next slide. So with the patch, you want to make sure that it's placed on a clean, dry, hairless part of the skin. It's usually between the waist and the shoulders where it's placed. And whatever that initial dose is to reach their current nicotine dependence, that stays on for 4 to 6 weeks. Then you lower it by 7 milligrams. So if they start with the 21 milligram patch, then their next dose is going to be the 14, and they're going to wear that for 2 to 6 weeks. And then after that, they'll go down to the 7 milligram for 2 to 6 weeks. And then hopefully they'll be able to not use a patch and not smoke at the same time. One of the common side effects from using a nicotine patch is sleep disturbances. So if they're experiencing that, they can take the patch off at bedtime and then put it back on first thing in the morning. And another common adverse effects is about 50% will get a skin rash, a mild skin rash in the area where they place it, which can be alleviated by not putting the patch in the same place day after day after day. And over-the-counter hydrocortisone cream can get rid of that rash. About 5% will have a severe reaction, and in that case, they get like welts all over their body, hives all over their body, so they would need to pick a different pharmacotherapy. Next slide. I'm going to talk about nicotine gum and nicotine lozenge together because they are dosed exactly the same. They both come in 2 milligram and 4 milligram doses. You select 2 milligrams if they can wait 30 minutes or longer before they use their product. And you'll select the 4 milligram if they need to use immediately upon waking within 30 minutes. With the gum, they can have up to 24 pieces a day. With the lozenge, for some reason, it's only 20. And the way you tell them to use it is, and this is if they're using just the gum or just the lozenge. If they're combining it with the patch, then they're going to use it when they either are experiencing a craving or when they know they're going to be triggered to smoke. But if they're just using it alone, for the first 6 weeks, they'll have a piece available and in their mouth every 1 to 2 hours. So it is consistent use, which makes it very hard to maintain. And then as the weeks go on, weeks 7 through 9, they'll try to extend the amount of time and use a piece every 2 to 4 hours. And then the last 10 to 12 weeks, they'll use it every 4 to 8 hours. Next slide. With the gum, you need to make sure that people know how to use these products. Because if you say, hey, here's some nicotine gum, it will really help you, and you don't talk through it, they're not going to know that they have to chew the nicotine gum until it releases a peppery or tingling sensation, and then they have to park it in their cheek. And that's when the nicotine is absorbed into their system. When that tingling sensation goes away, they take it out, chew it a little bit, and park it in a different area. And generally, this is about 30 minutes of use. And acidic environments don't allow nicotine to get into the body as easily. So it's recommended that they don't eat or drink anything within 15 minutes before using. They can also just put a little bit of baking soda and water and swish that around, and that'll make their mouth more alkaline or more basic so that the nicotine is readily absorbed. You can go. That's great. That was perfect. With the lozenge, it is the same milligrams. And again, it needs to be parked into the vestibule, so in between the cheek and the gum, and allowed to just dissolve slowly. When it's chewed and swallowed, it's not effective and it can cause an upset stomach. And again, no food or drink within 15 minutes, or just make the mouth less acidic by rinsing with baking soda and water. Next slide. The nicotine nasal spray is very expensive. It's not my favorite, although the one pro of it is that it gets to the receptors in the brain very quickly, within 5 to 20 minutes. Sorry, there is a little gnat flying around my face. It is prescription, so you have to either work with a prescriber or have prescribing abilities. They use 1 to 2 doses per hour, A dose is 2 sprays, one into each nostril, and each spray delivers about 0.5 milligrams. So together that would be a milligram. The thing that makes it really hard is the cost and the fact that they don't inhale it like other sprays that you put in your nose. So you have to tell them to kind of turn it toward the lining of their nose and spray it, and then just let it sit there and it drains out, and it's just hard for people to handle. They can use at least 8 doses per day, and the maximum use is 5 doses per hour, no more than 40 per day. Next slide. Overall, with all of the nicotine replacement therapy, if they've had a recent heart attack or their heart's racing or they have chest pain and they don't know why, they probably should go to a cardiologist and figure that out before they try tobacco cessation. Also, there aren't studies for pregnant women or breastfeeding, but we are not a lot. I shouldn't say there aren't studies. There are not a lot of studies for pregnant women or adolescents. So it's not FDA approved, but it is actually FDA approved. Sorry. The short release nicotine replacement therapy is best for pregnant or breastfeeding women. And if they select a prescription, they should probably have a meeting with their OBGYN before it's started. And then adolescents, there are not a lot of studies, so you need to make sure that their parents are aware. And with any of the medications for smoking, when tobacco smoke is heated, polyacrylene hydrocarbons are released, and it can actually affect how quickly medications stay in the system. So they need higher doses of some types of medications. I can provide a list of those for anyone that's interested, but overall it's insulin, some medications for asthma, some antidepressants, antipsychotics, and some medications for hypertension need to be dosed at a higher rate to be effective while they're smoking. And then when they quit smoking, those doses may need to be lowered. So it's important to know that list if you are a prescriber. Next slide. Next, we're going to
Actually, a
talk
comment
about.
in the chat. Sorry.
Uh-huh.
Dan had put NRT is in wide use in school-based health centers in West Virginia.
Excellent. Thank you, Dan, for all the work you've done to make that happen in this state, too. That is fabulous. So, Dan, at the end, I want you to talk more about that because he's been very effective getting vaping prevention into the schools. So that is fabulous. Next, we're going to talk about bupropion, which is the only one with the black box warning because it increases the risk of suicidality in young adults. The way we dose it is they start 1 week prior to their quit date with 150 milligrams for the first 3 days. And then the rest of the 12-week dose is 150 milligrams twice a day with 8 hours in between those doses. Common side effects, I think it's on the next slide. Common side effects with bupropion are insomnia, dry mouth, or nausea. And it's okay, you can go ahead to that slide. And of course, you want to tell the patient that it does have a black box warning. And if they become increasingly sad or not feeling the desire to live, then they need to immediately go off of it and they don't have to titrate back off. They can just stop. It is the only one with a true contraindication for use, and that is if somebody has a seizure disorder like epilepsy, or they are in situations which increase their risk of seizures, like somebody that has bulimia or anorexia, or they've abruptly stopped use of alcohol or sedatives. And of course, if they're on another antidepressant, you wouldn't want to double dose them. And if they have used an MOA inhibitor, then it should be stopped 14 days prior to using this. Next slide. Precautions for use are if they have liver impairment. You should work with their OBGYN if they're pregnant. It should not be prescribed to adolescents until they're at least 18 years old. And I've said everything else on the slide. Next slide. Varenicline, which is my personal favorite, as I said earlier, does require a prescription. It does not have a black box warning. That was removed with the large Eagles trial that showed that it did not increase the risk of depression, or didn't, even in those that already have a mental disorder. It is a little trickier to prescribe because you start 1 week prior to the quit date, as you do with bupropion. They start by taking 0.5 milligrams in the morning for the first 3 days. Then days 4 through 7, they're going to take 0.5 milligrams twice a day. And then weeks 12 through 2 through 12, they're going to take a milligram twice a day, or 2 milligram total dose. Common side effects are nausea and sleep disturbances. So one way to help with this nausea is to make sure they're taking the dose with a meal and a full glass of water. Next slide. Some of the precautions are if they have renal impairment. If they are pregnant or breastfeeding, it can't be prescribed until they're 16 years of age. And neuropsychic symptoms are rare, but they can happen with this medication, so they need to be made aware. Next slide, and I promise I'm almost done. Remember, we can combine these pharmacotherapy for people that have moderate to high nicotine dependence. And really, if you determine that with an assessment, you should start with combination therapy, especially with the patch and the short release nicotine replacement therapies. Or the patch can be combined with bupropion. It can also be combined with varenicline, or varenicline and bupropion can be used together. Next slide. So I've attached a tobacco treatment algorithm that was developed here at WVU with me and a pharmacist and a physician. On it, it has links for the nicotine dependence assessments for smoking, smokeless, and vaping. Once you determine their nicotine dependence level, then this algorithm can help you select an appropriate pharmacotherapy and just gives a really easy reminder of the doses that are needed for these. This is available through the tobacco treatment training program also. And I believe that is my next slide, but let's just make sure. That was my last slide. All right, now let's see if there are any questions regarding this information. I appreciate your attendance. There was a question, but I wasn't looking at the chat. Actually, it looks like Catherine Warner has her hand up. Thank you, Catherine. What's your question or comment?
Sorry, I didn't have a question. My phone actually died and I was trying to get back but no, I didn't have any question, but thank you.
You're welcome. I've done that before too. Was there something in the chat, or did we go through all of those?
We covered everything that was just during your presentation.
Okay, great.